Causes of hip pain in children. Children who have hip pathology can present in different ways, including complaints of pain, refusal to bear weight, limp, or abnormal gait, or decreased movement of the lower extremity. It's important to consider that in skeletally immature patients who have hip pathology may complain of pain elsewhere, usually the knee or distal thigh. And some patients may be too young to complain of pain. Causes. Injuries. Fractures and muscle strains and sprains near the hip joint are fairly easy to detect in older children and adolescents. But they are much harder to detect when infants, toddlers, or preschoolers get hurt. These younger children may not be able to explain that they were injured. Infection. Septic arthritis. Septic bacterial arthritis is the diagnosis not to miss in the evaluation of a child with hip pain. Given the potential for rapid joint destruction and long-term morbidity that can accompany delay in diagnosis and treatment. Children with septic arthritis of the hip typically are febrile and ill-appearing. Neonates and infants may present with irritability and pseudoparalysis of the affected limb, even without fever. Weight-bearing and motion of the affected hip are quite painful and strongly resisted in all patients. For diagnosis, laboratory tests have to be ordered. Diagnosis is confirmed by ultrasound-guided aspiration of inflammatory hip fluid with identification of a causative organism by blood or synovial fluid culture. Therapy consists of urgent and, in some cases, repeated drainage to avoid buildup of intra-articular pressure that may impede local blood flow, and administration of parenteral antibiotics. Be careful. Septic arthritis of the sacroiliac joint also can present as pain in the region of the hip. Osteomyelitis. Infections of the bones called osteomyelitis can cause hip pain. Since children's bones have a larger blood supply than those of adults, bacteria present in the blood can spread more easily to bones of children than adults. The proximal femur is the most common site of osteomyelitis in children. The diagnosis of osteomyelitis may be strongly suggested by plain film, bone scan, or MRI. Bone scan has the advantage of detecting multifocal disease, which occurs in 7% of cases of pediatric osteomyelitis, usually in neonates. MRI is more sensitive and specific than is bone scan in the diagnosis of osteomyelitis. Transient synovitis. Transient synovitis in children is a very common cause of hip pain. It is a disorder characterized by pain and limitation of motion in the hip. Your baby will cry when you move their hip joint. Fever typically is absent or low. Typically presents in patients between the ages of 3 and 8 years, without clear causes, and resolving gradually with conservative therapy. Legg-Calvé-Perthes disease. It is a syndrome of idiopathic osteonecrosis of the hip, also called avascular necrosis. Occurs when the blood flow to the hip joint and surrounding bone is temporarily interrupted for some still unknown reason. Typically occurs in children between the ages of 4 and 8 years old, and is more common in boys, especially those who are very active and who are short for their age. These children often have a painless limp, but then develop other symptoms, including hip pain and decreased the range of motion or stiffness of the hip joint. They may also have pain in their groin or knee. Diagnosis of Perthes disease demands a high index of suspicion, because initial radiographs often are normal. At this phase, bone scan shows decreased perfusion to the femoral head, and MRI reveals marrow changes highly suggestive of the diagnosis. Radiographs taken subsequently show fragmentation and then healing of the femoral head, often with residual deformity. Treatment may include physical therapy, non-weight bearing, The use of splints and surgery for more severe cases. Slipped capital femoral epiphysis. It occurs when the head of the femur slips along the growth plate away from the femoral neck. Symptoms can include knee, groin, thigh, or hip pain, hip stiffness, limping, and as it gets worse, a child may not be able to walk at all. Pain localized to the knee or thigh instead of the hip can lead clinicians to overlook the diagnosis. Slipped capital femoral epiphysis usually affects boys between the ages of 10 and 16, typically those who are overweight. This can usually be seen on an X-ray, which is the typical way to diagnose this condition. Slipped capital femoral epiphysis is treated with surgery, which holds the femur in place by screws and keeps it from slipping anymore. Systemic arthritis. Systemic rheumatologic diseases can present as isolated hip pain. Of these, the most common is psoriatic arthritis, which can start as isolated or recurrent hip arthritis. The skin manifestations of psoriatic arthritis may be subtle, such as dryness behind the ears or nail pits, and may emerge years after the onset of arthritis. Systemic juvenile idiopathic arthritis, Still's disease, commonly involves the hip, although usually in the setting of an obvious systemic inflammatory state with concurrent arthritis in other joints. Other arthritic conditions that can potentially involve the hip include Kawasaki disease, Lyme disease, acute rheumatic fever, and post-streptococcal arthritis. Osteoid osteoma. Osteoid osteoma is a relatively common benign tumor of bone that can present as a painful hip because the proximal femur is the most common site of occurrence. Although osteoid osteoma is seen in all age groups from toddlers to adults, most patients present in the teenage years. The pain is typically nocturnal and aching, and it responds briskly to NSAIDs therapy. The lesion may be visible as a lucency with surrounding cortical thickening on plain radiograph or CORT scan called a nidus, or it may be apparent only on bone scan or MRI. Malignancy. Malignancy presenting as arthritis occurs rarely but is well reported. Leukemia is the most common cancer to present as joint pain in children. These patients typically have severe migratory musculoskeletal pain secondary to leukemic infiltration of bone. Stress fracture. Stress fractures are rare in children, but they can occur in athletes engaged in endurance sports. Plain films usually are negative early in the course of the fracture. Bone scan or MRI are the tests of choice. A temporary change in activity pattern is important to avoid progression to a displaced fracture. Idiopathic chondrolysis of the hip. Idiopathic chondrolysis of the hip is a poorly defined condition in which the articular cartilage of the hip is injured by an undefined but presumably inflammatory process. Idiopathic chondrolysis of the hip affects females more than males, usually in the second decade of life. While symptoms are commonly unilateral, disease in the contralateral hip is sometimes noted on physical examination or imaging studies. MRI demonstrates cartilage loss and synovial hypertrophy. Although some patients recover, most go on to develop painful and disabling osteoarthritis of the hip. Diagnosing the cause of hip pain. Upon visiting a doctor regarding the pain, the doctor will ask if there has been fever. Other important aspects of the history include the onset, duration, severity, and location of the pain, associated systemic symptoms, past medical history, and family history. The doctor will also perform a complete physical examination of the child. The hip examination includes observation for asymmetry and position of comfort, palpation to localize the source of pain, and range of motion in the supine position. Abnormalities of other joints, the skin, and other organs can help to distinguish systemic from local disease. Radiographic evaluation is necessary in all children with hip pain. The initial imaging study is typically a plain radiograph of the hips in AP and frog leg views. The frog leg is the true lateral for the femur. Ultrasonography is an excellent technique for identifying small joint effusions and should be used when plain radiographs are normal. But the suspicion of septic arthritis or transient synovitis remains high. Ultrasonography also may be used to guide aspiration of the hip when that procedure is deemed appropriate. Use of bone scan may be of great value in diagnosing the child with hip pain. MRI and CT scan are used most often to pursue a cause of hip pain when other modalities have not been helpful. The laboratory evaluation of the child with hip pain is directed by the findings from the history and physical examination.